20 incidents a year, so it continues to be of significant concern. But overall, just the loss of control of material, so potentially harmful material, is a very significant issue worldwide. And those that are permanently lost are of greater concern because they're still in circulation somewhere. And importantly, this may only be the tip of the iceberg. This is what's been identified as lost, stolen or misused. There may be unidentified material in circulation as well. Maliciously, the material could just be an intact source placed somewhere under the lunch table today, when you're all in the queue for getting your lunch, for example, to irradiate a number of people in close proximity. It could be mixed with explosive material and detonated. Actually, somewhat less harmful. The explosion is the major issue, but it can contaminate a significant area, and the contamination may muddle our approaches to managing the trauma of the blast. But it doesn't take much highly enriched material to make a nuclear weapon. The US Department of Homeland Security has done some risk estimates, and they cannot even begin to estimate what the potential is for casualty numbers for nuclear weapons. And that's a 10 kiloton weapon. Most state actors have 100 kiloton weapons or more. Little Boy was 15 kiloton, and Fat Man, the bombs used in Hiroshima and Nagasaki respectively, was 20 kilotons, just to give you an idea of scale. And that was up to 250,000 injured or deceased. And I've included some other figures, but probably the one that's most relevant today is in fact the use of a dispersal device for radioactive material, mixing it with explosive. The dead would largely be from trauma. Extremely unlikely that any of them should have a radiation injury. But it's the numbers who are contaminated or perceive themselves to be contaminated that is the real issue. With larger nuclear weapons, perhaps what North Korea hopes to have eventually, in fact, the radiation fireball is almost consumed in the thermal injury. People are much more likely to die of thermal injury or blast effects than they are of radiation injury with the larger weapons. Some of the after effects can be mitigated. So, again, this is an estimate from the United States. People who are just caught in the open, and for figures they're using a city of about 10 million, okay? Those in the outdoor, there'll be about 750,000 categories. But if they shelter in the core of a significant office building, so one with multi-level car parks underground, either in the lowest basement or in the lift and stairwell, which provides the greatest protection, there may in fact be zero casualties from the fallout. But to do that, people need to know what to do beforehand, because communications will be affected and getting that message out would be extremely difficult. To think about potential impacts on a health system, Chernobyl is the worst disaster we've had to date, and yet the deaths due to radiation sickness were 28. There were some late deaths, generally due to other causes and not due to radiation sickness. And whilst there are a large number of thyroid cancers, they'd also stepped up their screening, so there was some detection of existing thyroid cancers as well. The real issue came from the social disruption of the massive evacuations and the consequence for that as permanently disrupted communities. Interestingly enough, and these were responders who had to shovel the reactor core back into the reactor hole at the top, these were the most heavily contaminated people imaginable. The medical staff treating them were able to minimise their exposure by simply adopting basic PPE. And and all they received was 10 millisieverts, which is half of the occupational exposure limit in Australia. Goiânia, a large city in Brazil, some scrap metal merchants got a hold of a radiotherapy source and prized it open and spread the glowing contents around. Children played with it. It was Mardi Gras time. Some people painted it on their skin. It was days before someone, astute enough to recognise that since that material had come into the house, her family had become ill. And this is actually a scenario that's not out of scope for a country like Australia. So there was delayed recognition of the illnesses. There are a small number of deaths. Importantly, when they invited people from the local neighbourhood to present to be surveyed for contamination, 112,000 people turned up. It took them 2 weeks in the football stadium to screen them all. These people will turn up to hospitals. Fukushima, in recent time, is much more of an environmental disaster than it has been a health disaster. In fact, the occupational exposure of most of the workers was well below the occupational exposure limit. And those who got higher exposure, none of them got acute radiation sickness or radiation burns. They volunteered to try and avert a wider community disaster. The only survivors of a radiation accident who've been so badly contaminated to be a threat to those treating them were in Chernobyl. And yet that was able to be managed. And the dress is something quite familiar to us. It is not respirators or anything particularly elaborate. It's very familiar garb. Radiation should be familiar to us, and yet most people feel very uncomfortable talking about radiation and feel that their understanding is not deep enough. In fact, the electromagnetic spectrum ranges from the harmless to the very short frequency, wavelength, high energy gamma rays. And it's when it reaches that point that they're so unstable that radioactive atoms shed enough energy that they have the potential to change the chemistry of another atom. That is what is meant by ionising radiation. And it's a cascade. With the change of an atom, a molecule is changed. If enough molecules are changed, the cell is impacted, and so on. And if enough cells are damaged, then an individual can become sick. The potential with the cell is that the cell could die from this effect, but it often just undergoes full repair. Each day, our bodies are subjected to 100,000 impacts from cosmic radiation, which, by and large, we just repair. But it could potentially cause a mutation, and the most sensitive cells are those that turn over most quickly. So the effects in individuals are about the acute effects, the high-dose effects. You need a big dose to get these effects, and the bigger the dose, the more severe. It's very much dose-related. With the late effects like cancer, it's about the probability. Now, for any individual, their probability of getting cancer sitting here without the radiation incident is 2 in 3, a lot of which is skin cancer. That's the average Australian. And the mortality for Australians from cancer is around 1/3. That's the background. What the radiation adds is it increases the probability that you're going to get cancer. Again, not at such high doses that you've got radiation sickness, but at very little doses, it's a very minor increase in your risk. At bigger doses, that risk increases, but its probability, because for each individual, it's all or nothing. There are no observed hereditary effects in human beings. Long-term studies of the atomic bomb survivor cohort and radiotherapy patients and their offspring shows that there's no transmission through the generations. There are, however, studies on fruit flies, because of rapid generations, that there is some effect in animals. So cautionary approach is warranted. What it doesn't cause is it doesn't cause immediate death, burns or wounds, and rarely ever causes immediate collapse. Irradiation or radioactive contamination aren't medical emergencies in themselves. It can cause nausea and vomiting. The earlier it comes on, the bigger the dose that someone's been exposed to. It can cause immunosuppression. It can cause death from shock. To get acute radiation syndrome, you need a very large dose, and it works by two principal means. It either interferes with the cell line so that the cells can't regenerate, or it causes microvascular injury. And generally microvascular injury, the type that you see with gastrointestinal radiation syndrome or cerebrovascular radiation syndrome, is not survivable for a whole variety of reasons. The early signs and symptoms are non-specific, and there's a classic waveform of a prodromal illness, a latent period with partial recovery, and then the acute illness, from which your choice is either survival or death, essentially. And with best treatment, that seems to be that at 60 days, about 50% of patients exposed to 5 sieverts will survive. And the treatment's largely supportive. It's what you might expect. Irradiated blood products to avoid graft versus host disease is probably the one that's not obvious. However, the treatment of acute radiation syndrome, in particular the recovery from the immunosuppression, the optimum treatment now, the consensus is that colony stimulating factors are the most desirable and started as early as possible. Bone marrow transplant was novel and used in some of the Chernobyl victims, and it turned out that the survival was poorer with bone marrow transplant, generally because people don't have total bone marrow ablation because their exposure tends to be uneven, so they get graft versus host disease, which is an issue also with stem cell transfusion. Despite optimal treatment, the 12-month survival above 6 Gray appears to be non-existent, and survivors of acute radiation syndrome go on to have a number of other long-term health effects. But it doesn't have to be whole-body irradiation. It might be local irradiation, affecting fertility, vision, hair loss, or injuring the skin. And rather than explain all the stages of skin injury, this gentleman picked up a radiation source, popped it in his pocket at a mine site, didn't know what it was, and wore that in his overall pocket for the next 8 hours. This was the cause of his injury. 2 days later, he's got a burn, but no history of chemical exposure or thermal injury. Within a week, necrosis is showing. But the ultimate result was he lost the leg, had an ongoing perineal injury that was difficult to manage. From that to this, how do you tell that man that perhaps years of suffering might be short-circuited by removing what appears to be a healthy leg early on? How do we, as doctors, determine what the eventual extent of this injury will be? An unresolved challenge. Radiation injury plus trauma is more fatal than either alone. And there is the potential for internal contamination if we breathe contaminants in, swallow them, or get them in wounds. Dirty wounds are a bad thing. It's a very simple surgical principle. What happens depends on the dose, and until recently, nobody had ever seen acute radiation syndrome from internal contamination. Alexander Litvinenko was a dissident Russian journalist in London who was poisoned, allegedly by a couple of KGB operatives who added polonium-210 to his tea at a cafe, at a meeting he'd been invited to. The challenge is that There was delayed recognition because they thought of other causes of poisoning first. And in fact, it was at the point of his post-mortem that they recognised what the problem was. Interestingly enough, was the extent of contamination from this tiny amount of material throughout London and the number of other people who showed evidence of contamination. That has a huge impact on the system. What do they do when they get in the body, radioactive materials? Well, some of them are just isotopes of essential elements. Some of them are analogues. So, for example, strontium, radium and plutonium behave like calcium, so they'll go to teeth and bones. Some will deposit in liver and kidneys and spleen, and uranium actually is not significantly radioactive in the body. It's a heavy metal, and it will poison your renal tubules. How do we treat this? Anything in black is unproven or irrelevant. The ones that we focus on are things like the alginates, things like Gaviscon, and the antacids, Prussian blue, and urinary alkalinisation. There is pulmonary lavage, and this isn't a few mils instilled and washed out. This is whole lung lavage. This is a technique that's really only used for pulmonary alveolar proteinosis. I believe there's a number of cases up in Brisbane of this, so this is a technique that is actually practiced locally. There is some evidence, a lot of evidence in animals and one case in human beings for its effectiveness. Blocking agents are fairly simple. We're talking calcium to replace strontium, plutonium, radium, or potassium iodide for radioiodines. And antidotes and decorporation agents suffer the problem of often being orphan drugs and with limited availability. The issue with administering something like stable iodine is its effectiveness decreases rapidly within the space of hours. So it's only about 50% effective within about 8 hours. Needs to be administered promptly during first exposure or in a situation of ongoing exposure. It's better to avert the exposure by sheltering in place, by removing it from the food chain. But the good news, we can detect and measure radiation, which means we can actually quantify exposure risk and therefore manage it. So, less time exposed is less exposure. If we're further away, you double the distance, you take it up, you cube the exposure by inversely. Shielding, depending on which type of radiation is emitted, and you avoid internal exposure and manage contaminated wounds and skin. Understanding what distance, there's a lot of knowledge about radiation. We know about these high-level sources. And basically, if it's intact, 30 metres is a safe distance. If it's a very large spill or there's smoke or mist, then 300 metres is where you want to be away from the source at least. Decontamination is a very straightforward procedure. It's not fancy. At the scene, it basically involves removing the clothing and then managing any residual contamination by cocooning the patient. Treatment priorities, trauma first, it kills faster. And manage and decontaminate when you've got some basic life support in place. Avoid harsh scrubbing because abrasion will increase the absorption of radioactive contamination. Assuming that these are the key points, starting with an all hazards approach because you need to think what other threats are there in this environment, we can actually manage these patients. And if it's been an explosion which is otherwise unexplained, you might want to screen for radiation. Everyone's on the same page with radiation, and the page is blank. So you need to know where you turn to for advice. There is a wealth of information out there and technical support. There are Australian clinical guidelines for radiological emergencies, which are quite comprehensive. And this is probably the pick of the websites. It's a US one. If you Google REMM, it'll take you straight there.
Thank you very much, and that was wonderful. So, folks, we're not in a terrible rush because Anita Green, unfortunately, is unable to join us, the last speaker on the program. So we've got a bit of time for relaxed questions, if you like. So may I just ask, is there anybody out in the audience that has any burning questions of Jane?
There's a microphone at the front here and in the back too, if you need it.
All right, while people are considering questions, I must say, Jane, we heard from Dr. Gareth Davies yesterday about the London bombings, and indeed he spoke about the pragmatic and incredibly brave decision that someone made with respect to deciding that there was no biological or nuclear component to those bomb blasts. He also made the point that London at the time only had 2 of those units that would be able to determine whether such involvement had taken place. They now have 4, and he spoke about the time delay. In the dreadful event or catastrophic event that we experience a similar terrorist attack, how would we be placed to make the decision whether we're dealing with something even more sinister than a simple thermal explosion?
Okay, I'll rule biological out. Biological material will be consumed in the heat of an explosion. Poor way to try and disseminate it. In terms of radiological material, and it's also a fairly poor way to disseminate chemical unless you get the proportions just right. And there's a lot of experience, sad to say, with chlorine and explosions in the Middle East. With radioactive material, many, but not all, of our fire services have radiation detection capability. Okay? Their first response to explosions and the aftermath, quite often. I can confidently say for the eastern states that's true, perhaps with the exception of Tasmania. In terms of hospitals, Victoria's actually equipped its public emergency departments with radiation detection equipment. All hospitals have some, because they deal with the radiopharmaceuticals for nuclear med and for some treatment. They must have Geiger counters to manage small spills. So they'll have at least one, and one will give you the start. Because if you find contamination, and really you can be quite strategic. The most heavily injured are most proximate to the event and will have the most heavy contamination. So a quick survey of that patient's going to give you some confidence about whether or not you're dealing with that.
And in terms of being at the scene, you know, I can see when they get to hospital you could use a Geiger counter and see if there's been exposure, but do we have things in place to assess the scene straight away?
There'll be many priorities at the scene in terms of making it safe and rescuing people. By and large, the ambulance services do not have the capacity to screen. They're reliant on the fire services. So it's a question of, this was deliberate, have we thought of it? Has someone asked the question? If someone asks the question, the devices can be brought. They'll either be brought by the state regulator, by the fire service. Certainly all the hazmat units are equipped and are trained in detection. So they're the 2 first points of call in the field.
Thank you very much, Jane. Has anybody else got any questions out there at this stage of Jane?
Just here, sorry.
Oh, sorry.
Do you want to grab a microphone, if that's okay, just so we can hear?
There's a microphone down the front here, just whistle on down.
Thanks, Shane. Just a question. In terms of the exposure and trauma, where would the best place to take shelter be? And how could we practically give that advice to members of the public? I know, when there is a disaster, although we're critical care nurses and physicians, the huge proportion of other nurses may not work in that area, and so you're you know, as a health professional, members of the public, family are asking for information. So given this is, or seems to be, an immediate threat, what would be, if we were asked, where's the best place to go in an event this takes place, how could we confidently answer that to members of the public?
Go indoors, shut the doors, shut the windows, turn off the air conditioning. If you're in a multi-storey office block, shelter in the stairwell or in the lower basement car park. If you're at home, shelter in as far from the windows as you can in your home. Even if you're on the road, being in your car is somewhat protective. So you'd still turn off your air conditioning and have your windows closed. They're the basics. People should understand this. They need to know this for more than radiation. They need to know this for chemical releases. They need to know this for fires and protection from smoke. So this should be fundamental community knowledge, and we need to make sure that people understand this thoroughly. The emergency services in most jurisdictions have reached the point where they're now issuing emergency alerts, and what's really important with the message is that they give a consistent message, because if people get different messages from different sources, they don't believe any of them because they don't know who to trust. It's really important to tune into what the emergency management leadership or the public health leadership in your jurisdiction is saying and repeat their message.